Thank you, Chair, and thanks so much for being here. So I'd like to ask you a few questions about local leadership and then place-based approaches, which you're all very aware of. So Beth, I just want to start with yourself around the Greater Manchester's Ageing Hub. Am I right in thinking that it's been going since 2016, is that right?
Yeah.
Excellent, so that's nearly 10 years of data and evidence, which is fantastic. So I wonder if you could just say to the committee a bit about what you think has been the really key thing as to why this has worked well, and then it'd be really helpful to hear about anything that hasn't worked well and why it hasn't, and what you've learned from that.
Yeah, absolutely. So essentially, the Ageing Hub model, we're unique. We're the only one in the country, and we have a team of around 10 people now, and we've developed an ecosystem of age-friendly partners, and we work fundamentally with organisations across the GM system.
Sorry, Beth, just to be specific, these are the things that are working well. You're telling us this is part
absolutely.
of the success story. Great,
yeah,
so if you can just be really clear, that's great. So this is why it's working well.
I'd say one of our fundamental successes is working with research institutions and our universities in Greater Manchester, who are world leaders in healthy ageing and provide us with an evidence-based approach to everything we do. We work very closely with our Manchester urban ageing colleagues to look at spatially where are people ageing, how are they ageing, and layering that on with the health data that we have as a system. We work very closely with the voluntary sector, national partners, so the Centre for Ageing Better, National What Works charity on ageing. But fundamentally, our biggest success is our integral approach to embedding the voice of older people, but not just the voice, but the lived experience, and centering them in everything we do so that it is led by our communities, and we essentially hearing what needs to change.
Okay, so that seems very good. In terms of funding, do you have enough funding to do what you need to do?
No,
Right.
Absolutely not. So fundamentally, we have one core funded member within the organisation, and our funding is through constantly looking at different bids, funding streams, philanthropy. We've got
So that takes up quite a lot of energy and work,
yes,
right? Yeah,
and
okay.
We are on short-term contracts. So predominantly all our team are on 12-month contracts, and as soon as you're 3 months in, you're then looking to continue the work and constantly advocating for the need for older people to be embedded and our work to be embedded across the organisation.
Just to stick with funding a bit, your funding is predominantly grant funded. You're applying for grants all the time.
Yeah.
Okay, that is quite work intensive. And I mean, it sounds like it's a good model. It survived in 2016. That's great. Is there anything that hasn't worked during that time, and lessons learned from that?
I'd say some of the things that don't work is because we've no national strategy on ageing, there is no actual requirement for us to deliver on this locally. Luckily, we do have Andy Burnham, who is a huge advocate for our work, but actually the ability to influence local leadership and how we embed this in across policy doesn't always work. People have views. We've got entrenched ageism within our systems. People always challenge us on, well, we're starting with prevention in children and young people, but the challenge is we can prevent at any age. And we know there's a huge amount we can do in people in mid to later life to really change that trajectory and reduce the cost on the NHS. So that will be our biggest challenge.
So that's really interesting. So just thinking, obviously we're ageing well here, but ageing well means from 0 to 100. Absolutely. Basically. It's an ageing well philosophy. So your Ageing Well Hub, how does it interact with the other sort of age groups? How does it sort of embed not only the voice of older people, but the interests and thoughts of people who are going to be older one day anyway? How does that work?
So we sit within Public Service Reform Directorate. We've got a Children and People's team, we've got a homelessness team, asylum team, and we look at everything through a public service lens of everything we do and everything we deliver and support our localities deliver. We need to make sure we've got that whole view of every cohort. So what does it mean to layer an age angle onto all those other areas? We have work around intergenerational approaches to ageing and how we interact with other parts and system and policies. So we can't just look at ageing as a silo. We've got to absolutely make sure we're approaching this as a whole population.
Great. And just to be clear before we move on, for your Ageing Hub model, your mandate is from the Greater Manchester Authority and leadership, basically, in the sense that you exist and you get sort of endorsed at a Greater Manchester level, but you perhaps feel that the national, because of the lack of a national ageing strategy, the national mandate would be helpful for your Ageing Hub to sort of develop and thrive.
Absolutely. We have huge recognition globally. We've got, we only had Amsterdam coming to visit us last week to learn about our approaches.
You get to go to Amsterdam?
Unfortunately not. They'd much prefer to come to Manchester.
Good things about Manchester.
But it didn't rain, so they were really pleased. The actual ability for us to, and we very often get questioned, why is this not recognised nationally here when the work you're doing is world leading?
Right, you've just reminded me, actually, you were the first World Health Friendly Ageing City, were you, or something? World Health Organisation's Global Network of Age Friendly Cities. You were the first one in the UK, is that right?
We were, yes.
Fantastic. And so you've taken presumably global learnings as well.
Absolutely.
And they've learned from you.
We've got eight core age-friendly principles, which we think don't have to be age-friendly. If you adopt those principles, transport, housing, social participation, civic participation, green and blue spaces, etc. If you look through that lens and make sure it's accessible for all, we will support people to age well.
Lovely, thank you. That sounds very comprehensive. So if we sort of take those themes, and Siobhan, if I move to yourself, and Ryan, and I wonder if you could talk about your roles in local authorities and the local place around how age-friendly principles could be, should be, or are embedded in planning. And by planning, Siobhan, feel free to talk about local authority planning, it's very interesting, and commissioning of services. Would be really interested to get your thoughts on that. Whoever wants to start, to go for it.
So in terms of planning, I think it's I'm really glad you've raised it, because with the ambition to build 1.5 million homes, there is a huge opportunity to embed physical activity into those communities that are being built.
How are you finding that? Because public health is not a statutory consultee, is it?
We are involved very closely in the local plans. However, the challenge is, of course, that once your local plan is set, each individual development requires planning permission. And so there are often, I believe, viability arguments made against why some things can or can't be delivered within a local development. And I still wonder whether or not the national planning framework goes far enough in terms of setting expectations around well-being as a whole. So things like green space, blue space, transport, connectivity, lighting, so all of the things we've heard about already today. So there is
I couldn't agree more, Siobhan. I just want to, and I think you're completely right around the National Planning Policy Framework. It's an ongoing conversation. In terms of ageing well, for planning, right-sizing the accommodation, how do you find that in your area? How's that going?
Yeah, so I mean, again, adaptability standards or accessibility standards are absolutely key. We've got an ageing population. I think our figures are something like 38% increase in our over 65s in Gloucestershire by the next 15 years. That's incredible. And again, if we build homes that are accessible to anybody in a wheelchair from the start, they will be right for most of our population for the rest of their lives. And again, it comes back to viability arguments and about the extra cost that costs the pound of the developer. And I think that I do think national government could be stronger in those expectations.
You mean very diplomatic, Siobhan. I completely agree. I think I think the NPPF is a real stumbling block actually for the ageing well issue. So I think you've really hit on something there. Right, I wonder if I could just bring you in. Thank you, Siobhan. Around perhaps the ICB, they're becoming the strategic commissioners. There's all that shift. Ageing well in a sort of commissioning strategy. How do you think that currently sits, or how should it sit?
I think it goes back to integrated care systems. So I don't think we should just purely focus on ICBs. They are a strategic commissioning lead at a local level.
Well, they're not yet, but they're going to be.
They're going to be, yeah. And I guess actually from our point of view and the work that we do, they are our biggest. They are already, and they are performing that function for us. But working alongside public health, adult social care, and the different level of maturities that each one will have within each place. From our perspective, the ICB is really, really proactive in commissioning towards physical activity and the work that can do from an ageing well perspective. It's very focused in and around deliverable models. So what can you still show us in terms of KPIs, outputs and stuff like that? We want to see numbers of people flowing through, which is fine, we can demonstrate that. But it's not so much, there's not that great belief yet from a commissioning point of view in terms of the longevity of change, which I think is what we need to, a point of where we need to get to.
Why is that, Ryan? Why do you think that's the case?
I think that comes from financial pressure, to show that you are achieving against your goals in a quick state, and that's historically put pressure on the sector from a physical activity point of view, which gives unrealistic achievements and goals, which is why we find ourselves in this point now from an ageing well perspective. So we've had falls services decommissioned across the country for years because they've been asked to fix falls prevention in a 6-month time frame, which just isn't feasible, and if it doesn't do it, it's seen to fail.
And so just to sort of push you a little bit, so with the NHS 10-year strategy, and we hear once again the mantra of treatment prevention, which we've all heard for quite a long time, but here we are with a renewed focus. Do you see any change, any shift in the local conversation with the NHS 10-year strategy giving that more national push again?
Yes, you see change in the conversation. I think you see willing in the people that are working at that level and a belief to do that. I think you also see constraints in their belief to be able to shift, to be able to make the change. I don't think they feel sure in how to do that for certain at the minute. And it comes back to the point of permission giving around how, if we're writing a 10-year strategy, why aren't we commissioning for 10 years?
Very good point, Ryan.
And then why aren't we measuring the right things? Rather than measuring the big outcomes, measure the impact of the intervention that you're putting in place.
Excellent, thank you, that's very clear. I wonder if I could just move you all on with the last few minutes I have to health inequalities. So I've heard some great things about your place-based approaches. In your time, in your experience, in your roles, what evidence do you have for the committee that these place-based approaches are actually reducing health inequalities in this particular age group? So, Siobhan, I'm going to start with yourself.
I think it sort of relates to Ryan's point, really, in that some of the outcomes we would need to measure a reduction in health inequalities are very long term. Okay. So it's difficult to say, oh, here's an intervention, we've done it for a year and therefore we've reduced inequalities, particularly if you're looking at something like healthy life expectancy or years lived in good health.
Sorry, you're the DPH, right? So in your directorate, what's the longest running programme you've got that relates to this particular area?
It's usually within an election cycle, so it relates to usually our council strategy.
You haven't got any 10-year programme running for ageing well?
We have a 10-year health and wellbeing strategy.
Yeah.
However,
the same as a programme.
Within that, the way we then deliver that is changeable, probably on a 4 to 5 year cycle. 4
to 5 year cycle. So your 10-year health and wellbeing strategy, your sort of outcomes, indicators of success in that health and wellbeing strategy, in terms of reducing health inequalities, are you seeing a substantive shift, or is it disrupted by the electoral cycle and the commissioning?
I think it's not just electoral cycle and commissioning. I think organisational change.
Yeah.
So again, I think we are now. If you look at Gloucestershire, we're going through local government reform, integrated care board reform. Office of Police and Crime Commissioner will be changing. I believe there's going to be a police review imminent. So that is our entire system changed. And what we've got to do through that period in order to keep it working and to reduce inequalities is to maintain the relationships, not just with other statutory sector partners, but with the voluntary sector. And we've heard so much about the role they play. I think we've got early indications through our health data about the number of people that we're reaching, but I would say at the moment it's probably more output data than outcome data, and I think we will need longer to understand if we're really truly affecting outcomes.
And just for context, your inequality data in your part of the world, is it worsening, getting better, staying steady state? What's it looking like?
We've got an ageing population.
Yeah.
And
but all things, if you sort of account for all of that, how's it looking?
I suspect it's getting worse. I think, we have challenges around cost of living nationally. We see the impacts of that. And I think the way we are able to understand what's happening in the local population is through things like what comes through the Citizens Advice Bureaus, so what people are accessing support for, which they maybe weren't 15, 20 years ago. Food is a huge issue, and I know we're talking about physical activity today, but it's all related to, ageing well and being well. Yeah. So even in parts of the Cotswolds, which people would imagine as chocolate box villages and very affluent, we have some incredible rural deprivation, which is.
I think we're going to come to rural poverty. So hold that thought.
Just to say, there are food banks there.
Of course. Yeah, absolutely. Beth, I wonder if I could sort of ask yourself, and perhaps as Siobhan has said, we're looking at physical activity. So have you got data that shows perhaps the physical activity aspect of your ageing hub is helping to reduce inequalities in this age group?
Yeah, absolutely. We've got some great examples of our work with GM Moving, which are a local active partnership. We delivered back in 2018. We looked at an active ageing programme, which was all about place-based led initiatives in some of our poorest neighbourhoods with poorest outcomes as to what would it mean for you to engage in physical activity. And we're starting to see through some of the national data that GM is starting to reduce that gap and that inequality gap, which is great. Other examples of looking more broader, not just through a physical activity lens. We have an Ageing in Place Pathfinder programme, which we delivered over the last 4 years, which was the foundations were all about voice, data-led, working with local leadership and stakeholders. And there's 3 simple questions we went out in communities, door knocked and asked, what's it like to live in this neighbourhood? What would make it better, and how can you work with us to improve it? Really, really simple. Fundamentally, a lot of those barriers were things like that, we needed to bring planning in on pavements weren't accessible, people couldn't get out and about and feel steady and safe. One of the really great examples was what we found was people weren't attending the GP surgery. They weren't going to take, appointments were really poor. And what we knew was actually the neighbourhood we were working on was on a hill. And actually people could get down to the GP surgery but couldn't get back up, and what was on top of the hill was A&E, so they would go to A&E instead. And we found that out through door knocking to understand why people weren't. We've now worked with the GP, and they now come up on the hill and do a pop-up clinic in our community hub where we've got a green allotment, we've got places for people to have a brew and chat, they embed themselves in the neighbourhood, they've built that trust, and therefore people are now, and we've got 100% attendance in that surgery.
Beth. I love that.
That's
Thank
a practical example.
Very good, thank you. And very quickly, Ryan, I'm pretty much out of time, but are there any particular indicators that you think would allow us to track sort of the reduction of health inequalities through physical activity that we're not doing at the moment, perhaps more, ones with more longevity than we're seeing?
I think it's about getting the assumptions right with any programmes and work that you put in place. There's a strong literature and evidence base around the benefits of physical activity now, so lean on that, don't measure that now. So how we're functioning is, at the moment, we aren't going to be able to distinctly measure the impacts we have on health inequalities. That's a longer term plan, but we can show that we're engaging with the right communities, the right people, and if we're getting them active. And the assumption is, if we're engaging with the right people and getting them active, then the big change should come.
Right, thanks so much, Ryan. Thanks, Jeff.
Thank you very much.
Right.